been at NAP, I think, for about a little over a year, maybe a year. And she's been working with kids, adolescents, families in her time. And she really loves working with teens, young adults, especially with our topic tonight, eating disorders. She has experience working at Boston Children's in private practice and UMass Amherst. And she's been in not only this area, but also Washington, D.C. and Maryland and Atlanta, Georgia. So she has a lot of experience around the country and also working with diverse populations. She'll probably tell you a little bit more about herself tonight as well. So without further ado, go ahead, Veronica. Thank you.
Thanks, Anjali. Hello, everybody. Quick sort of extra background on me is that I've been doing eating disorders since 2008. So I've done a variety of settings, and partly I do this work because I absolutely love adolescents. I love kids, and I feel like eating disorders, when they're very intimidating and intense for families and patients and kids, and trying to treat them at a younger age for me is both important because I like kids, but also I think in terms of them getting into adulthood, dealing with an issue like this can help pave the way into adulthood. So hopefully, ideally, they don't have any of these issues and they spend their adulthood in freedom from some of these issues. The other thing that, based on what Anjali said about my teaching at UMass Amherst, I don't work in the counseling there. I actually teach a sociology of eating disorders course at UMass for about 7 years now. So I created a class to teach to undergrads in an attempt to kind of deal with this issue on like an academic setting, not just clinical, because I do find it both academically interesting and sort of the intersection of all these disorders and the parts that interplay with it, but also I thought maybe I could reach a bigger population by working with college kids to kind of stem the flow. So as Anjali said, if you have questions, there's going to be 2 quick little writing exercises for yourself. So if you have a piece of paper to either write your own questions down or to do these exercises, that would be great. And I'll just quickly show you a short topic list. Oh, the other thing I wanted to say is in the chat now, what would be really helpful is if you could put down not a question yet, but well, you can write questions, but a topic or like a subtopic of this this category, eating disorders, et cetera, that you're coming here for, so I can tailor some of it to that, because it really is a broad topic between prevention, early identification of the issues, and once you're really in the issue in terms of treatment. So if there's a particular interest with you all, sort of subtopic wise, can you let me know? And I'm going to share my screen with some topics that I have. I don't have to do definitions of eating disorders, but if I have, certainly can do that if people aren't as aware as they want to be on the latest about that. Child development a tiny bit. Social media, of course, a lot of parents usually have questions about social media. And then also dealing with eating disorders or prevention of eating disorders at the medical home and how that works with you all and your kids, and also treatment approaches if needed. But let me just sort of see what's doing with that chat already. I'm curious. Can you explain more of that, Ms. Kelly? Or just type it? I can't. I don't even actually understand what that topic means.
Sorry.
So if you'll lose the second one, but go ahead.
Yeah, so my kid does fine eating at home, but is not eating at school.
Oh, okay. 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 Yeah, this is such a complex issue.
Yeah, mine is pretty much the same. It's not eating in school, thinking food might be poison. Small shops looking at everything. Do I see something black in there? What does that is? Picky,
Okay.
real picky.
Okay.
And among other things of getting rid of some portions and lying about that she ate when she didn't and stuff like that.
Okay.
Not eating in school is a big one too.
Okay. Anything else? I am going to remind you this, I probably said this is not going to be, I can't offer, in-depth clinical assessments right now, but I do want to be able to touch upon some of the, and I'll show you the different types of eating disorders, and you'll see some of you already just mentioned something that will be in one of my slides. So hold on, let me get my slide thing. Okay, but before I get to that, sorry, I'm trying to toggle between things here. Okay. Everybody can see that?
Yes.
Okay, thank you. Eating disorders, and this is part of the blurb, eating disorders and body image can be intimidating topics for parents. With the additional pressure of of diet culture and social media, it is hard to know what to look out for, how to talk with kids about it, ways to prevent it, and how to address it in the doctor's office. Let's start with a basic premise that psychosocial, that eating disorders are truly a biopsychosocial illness. They're biopsychosocial illnesses, which means that there's a confluence of, this is like a Venn diagram, there's a confluence of biology, psychology, environment, so nature versus nurture of your children. And so for every kid, it's different. So every single assessment I do, I ask about, genetic, biological, nature aspects of your kid. And then we also talk about all of the psychology, sort of emotions, coping, personality, and then social, like where they, everything from home environment to schools to experiences of trauma, which is also in psychology, but the context of trauma, like if there's ongoing trauma in a house, the social context trauma, that can have an impact. So eating disorders really are truly a biopsychosocial category of illnesses, and how we treat them is a similar Venn diagram as well. And the reality is that there's a range of triggers for eating disorders. When we get to the early identification, I know there was a parent in there who already asked about early identification. When we get to that, the truth is there are sometimes one trigger for an eating disorder, and sometimes there's a confluence of 5. And we'll get to some of the differences between 1 and 5. And the other problem with eating disorders, like I'm going to give you all sort of the confounding, like I understand why it's an overwhelming issue. Because, hold on, where's my other little thing? Eating disorders are often rewarded in our society by comments about you lost weight and you look great. So eating disorders in some ways, are the umbrella term for body image issues, disordered eating, all those things. But eating disorders are one of the only mental health issues in our society that are rewarded or complimented or validated in a positive way. Unlike depression, when someone tells you they're depressed, you usually want them to feel different. You don't want them to be depressed. You don't, and so it's identifying eating disorders is sometimes very hard because eating disorders often develop within the context of positive reinforcement for healthy eating, changing your diet, trying to lose weight, or a lot of, and even more simply, negative body talk, especially for girls, is so common and so culturally normative that when kind of negative throwaway comments turn into more sort of sticky thoughts and increase in behaviors. It's a hard threshold to see when they've crossed it, especially when you're a parent, and especially when you see your kid every single day. It's difficult to know when something is just a throwaway comment, like, oh, I don't like my hair today, I don't like this outfit, and when that starts to build up into sort of cumulative, sorry, I got tired of myself, cumulative negative self-talk and sticky, like I said, I call them sticky thoughts. So in that way, I wanted to sort of say that eating disorders kind of follow in our mind, provider mind, an addiction model, kind of the same way that, like, it's different than using drugs, but it's a similar, you think that you're sort of you have things under control, and you're maybe dabbling in some eating disorder behaviors. You may like change to tweak one thing, and then you're like, okay, I'm just not going to do any more tweaking, and I'm good right now. And you know, the problem with some of that is that the body likes to kind of likes the ritual, or likes the changes, or likes the compliments, and then kind of like other in sort of the addiction model, they build on itself, and it can be difficult to pause or take back some of the rituals and rigidity. I want to do a quick exercise with you all for a second. Can you see this slide? Yes?
Yes.
Okay. So if you can take a second, because part of this is about my prevention work with when families want to talk about not just how to identify in their kids, but when they're talking, I do a lot of parent consults, and they ask, how can I think about it in my own household? How can I role model a healthy or a strong relationship with my body? Part of what I have parents do in the consult is even just to think about their own reactions to these words, to think about what their visceral reaction is to the word fat and appetite and hunger and diet. Is there, fat's obviously in our culture is a third rail word, and there's a lot of cultural movement towards destigmatizing the word fat. But what about appetite or hunger or diet? Like, what do you feel guilty for being hungry? Is that a loaded word? Does diet mean always trying to lose weight? Does it mean chasing something? Does it mean capitalism? Does it mean or does it mean what your body's consuming? And I use these exercises for patients too, because the reality is so many words associated with body and food before they even get into eating disorders. So many of these words get associated with morality, right? And younger kids, especially their younger brains, ages 8 to 12, and they're starting to sort of come into the more moral, relational parts of their brain. They're trying to understand what it means to be good, and what it means to be not just a nice person. We talk so much about being nice and not being a bully to others. We talk about social emotional health. What I have found, I'm getting ahead of myself, but what I have found in working with schools is that we talk a lot about social emotional health with getting along with others, but we don't talk a lot. There's like the bullying and get along with others, and sometimes there's sexual harassment for older kids. I don't find a lot of good conversations about what does it mean to have moral feelings, equating a very primal thing like appetite to morality. And so when parents out here are asking about prevention, identification, part of it is kind of deconstructing in your minds how you associate with these words and how that's being talked about in your own home. That's sort of the prevention. Sorry. Okay, so you don't have to share it. You don't have to share any of that with me, but Is anybody, oh, was there any, Anjali, any of those chat questions are those questions in the chat for later?
No, but Taryn did share her first like impressions of those words that you were talking about in your
Oh, okay.
exercise. So
Cool.
do you want me to share it with you or?
Yeah, that'd be great.
She wrote that fat, her first impression or first thing that came to mind was bad, appetite good, diet is something you want and enjoy if it's a healthy one. Going on one is meant to lose weight, but it's very depressing to me. Luz said fat is not a nice word to say. Hungry means you eat something.
That's
Jared
great.
said fat is derisive, but I have no reactions to the other words.
Great. The thing about anorexia, this is obviously, remember my clinical lens is a little bit adjacent to all of you. And so my clinical lens is in experience is that especially patients with anorexia eventually hate having hunger, right? And so having hunger means they're failing at the disorders. So we'll get to, we can move that later, but I'm glad to hear that. I mean, obviously fat is a very loaded term and we'll get to that in a second. But I don't know, I assume most of you have heard of all of these. I'm not sure if any of you have heard of orthorexia. And ARFID is some of what I can hear in a parent or two here about avoidant restrictive feeding. What is I? I should know these, but
Intake?
What?
Intake?
Intake disorder? Yeah,
think so.
that's too clinical sounding to me. But ARFID used to be called picky eating. Okay, so we don't really use ARFID. We don't use picky eating anymore because it sounds more volitional, like that someone is volunteering to avoid, or that has a very rigid thought about, you know, being picky, and it almost sounds moral to me. I know it's not, but it almost sounds moral to me. So ARFID covers a wide range of disorders around avoiding food, which has less to do with body image. And what we're finding with ARFID is it can be, and this is like a much longer topic, and I'm happy for any of you to come do a parent consult with me at NAP, but ARFID is more a variety of umbrella, you know, kids who've had some medical trauma, who've had a choking episode, so they become afraid of eating, kids who are more specific to afraid of eating in social situations, that's more social anxiety, kids who have sensory issues. There's a link out there in the literature about neurodiversity and ARFID with textures and avoiding certain textures, even autism and avoiding textures. So that's a bigger, in my my desire to sort of elevate the conversation academically about some of these eating disorders, I like to sort of talk about ARFID versus picky eating with families. And yeah, there's a lot of layers to that. Orthorexia is the fastest growing disorder. It's not the most prevalent, but it's the fastest one, and is kind of linked towards wellness, the wellness culture in our society. It's more geared towards healthy eating. There's some underlying drivers to that. Sometimes OCD, sometimes anxiety, but it's what I've seen in a lot of teenagers and even young adults is like this push in our culture for wellness and clean eating and raw foods and it almost goes back to the moral piece. What back in the day, anorexia was sort of the moral equivalent, like being thin was morally good, and now being healthy and eating clean is morally good. So, well, I was gonna get ahead, but part of what shows me is that when we get rigid about any concept, anorexia or thinness or eating well or healthy, or if we become afraid of food, period, anorexia, bulimia, ARFID, any of it, binge eating, not so much body dysmorphia, but the top 1, 2, 3, 4, 5 issues is we could become afraid of food and what it does to our body. But food we have to eat to stay alive. It's different than my drug addiction model, right? It's different than that. You don't need drugs, heroin and awful stuff to live, but you need food to live. So it's threading a more complicated needle. Okay, if you have questions about that later, you can put them in the chat and I'll get to that later. Let me see what I have next, I'm gonna.
Person that just asked about orthorexia, was that, I know Veronica just went over it again. Was that enough? Okay, great. Thank you.
Okay, before I get to another slide, let me just continue by sort of talking a little bit more about these eating disorders. Eating disorders can be a slippery slope. They surprise patients and families. They can also be more calculated and intentional. They can also only be parts of what is considered diagnostically a disorder. So someone may be intentionally restricting every breakfast, but still eating lunch and dinner. Is it deeply impacting their functioning? Maybe not, but the process of becoming ritualistic or rigid about behaviors, even if it doesn't happen often, is what we consider part of a spectrum of disordered eating or complicated relationship with food, body, and exercise. So the parents who were asking about different settings, the diagnostic criteria is one thing. What meets the criteria for insurance purposes is another thing. But from a clinical sort of relational perspective and working with your kids, eating disorders are more on a spectrum for me. And it's often a case of how much distress is it causing your child, not just the physiologic, maybe losing weight, maybe exercising too much, maybe eating food to numb feelings. It's not just that, it's like how interrupting and distressing is their behavior choices. So if like they're not eating lunch at school every single day and their social relationships are suffering, that to me is not necessarily an eating disorder, but it's interrupting their lives. And for younger children and younger teens, when peer relationships are becoming important, first or second for them, and above anything else, and things that disrupt the development of peer relationships, that can be a big deal. So us saying, oh, they're skipping lunch or they're skipping breakfast, it doesn't seem like a big deal. The question is, how much is it distressing them to have that ritual? How much is it impacting their peer relationships? And whether or not they're experiencing other distress, like they're crying about having to eat food, or they start becoming more ritualistic about when they eat food. It's not just how much they lose weight, or if they're quote binging and things like that. It's really it's a combination of how the distress that it causes as well. Yeah, and the truth about eating disorders is they also hide in plain sight, right? They're kind of like drug use in this way, where there's a lot of confusion about whether or not someone is misusing or using a behavior to control something or to compensate for a feeling. And so boys often get delayed diagnoses, more curvy women, girls, sometimes, you don't necessarily know that they have an eating disorder. It's trickier, and they hide in plain sight because eating disorders thrive in secrecy, kind of like drug addiction too. They thrive in secrecy, and kids will say, I'm not hungry, I'm just, I ate at school, or you'll find wrappings in their room if they're, binging and trying to numb themselves that way. Or sometimes, unfortunately, parents have heard kids purging in the bathroom. So eating disorders are kind of like a chameleon. They shape shift to fit a kid's lifestyle for a while. And that can be confusing. When you guys are talking about early identification, it is difficult to see them when some of it becomes so normalized and integrated in their conversations about, I'm not hungry, I'm running to sports, I'm running to meet my friend. So the reality, it is hard to identify early. However, for me, and this is kind of like my very kind of zero tolerance for body hatred approach. Like, I don't like when any kid hates himself. So for me, a kid saying any level of, negative self-talk is worth monitoring about body, especially. And also, the reality is, developmentally speaking, even if our culture says eat healthy and diet and exercise, the reality is ages 8 through 14 and 15, if your kid is from age 8 through 14 talking about changing their diet, dropping things out, or even like I have, 12-year-olds who like want to go to the gym all the time. And I was like, I don't even know what gym was 20 years ago. There's just this sort of precociousness of healthy eating and exercise that starts early with your kid, which is different than sports. That can be identifying as well, and more just like what I call an orange flag versus a red flag. Let me keep moving here. What age, can I ask a question? Maybe you guys can put that in the chat. What age do you think, developmentally speaking, what ages do you think kids, like when I see a kid with an eating issue on any kind of spectrum of the issue, sometimes they've gotten to me by the time it's like taken root. Either they're not using behaviors, but they've got some strong body dislike. What age do you think is the average age for, if you control for trauma and trauma happening, and let's pretend it's not part of it, what age do you think kids become the first aware of like body size? You put that in the chat, what age you think that is? Anjali. Yeah, 8 and 9 is correct. Every patient I've ever seen can remember something between 8 and 9. It doesn't even have to be an environmental trigger, like, they were weighed at school, which is a whole different conversation. It can just be like this, sitting next to a friend and being like, why is my leg bigger than their leg? It can be as simple as that. And that's developmentally appropriate in lots of ways. That's not necessarily negative body talk. That's developmentally, like, their brains are becoming more aware of their social surroundings, and they're like starting, like I said before, they're starting to like compare, instead of parallel play when they're under age 8, they're starting to get to the age 8 and 9 of like, oh, I'm relating to this person next to me, and how, oh, that's a good question, Charlotte. Generally, yeah. I mean, developmentally speaking, yes. I could say, I don't know. I'm just trying to think whether or not the eating issues start as young, but the awareness, yes, age 8 for gender spectrum. I mean, I'd say 8 to 10 if I'm being like general, but I definitely 8 is very, 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 very common. And that's, I was a psych undergrad major, so I studied child development, and now I'm a social worker. So I really do sort of see in my practice how that awareness is sort of, it's developmentally appropriate for them to recognize themselves compared to others at age 8. So the question when we get to the prevention slide is, what do we do around, what is it around ages, really birth, but like 6 through 10 that can help prevent future problems, right? That's part of the prevention model, is to look more at what should be in place before the like light bulb goes off at age 8, developmentally appropriate light bulb goes off at age 8, 9, and 10. What would help buffer? What would help earlier buffer when their social awareness pops up? We'll get to that later. Let me see where I am in my slides. Okay, I want to do another quick little. This is going to tie into prevention as well. I want, since we're talking about the age of kids, 8 and 9 and 10, I want you all to do another exercise with a little written thing here. I'll put this on the side share. I don't know why I always yell on Zoom. Sorry about that. It's like, can people hear me? Okay. Oh, that's a problem. Okay, let's go here. Okay. We're going to do this. So this is a little exercise as well. This is more about you and recognizing your kid, thinking about temperament and personality traits. This is the nature piece. This is what they were born with. This is part of my assessments. Whenever I meet a new family or a kid, I always ask about what was your kid like at age 2, around sleeping, eating, energy, all those questions. Because honestly, temperament is part of where I see the through lines for some of the eating issues. And it also helps me with my interventions later on. So it helps with assessments and treatments. And for you all, and for even the doctors, the earlier aware of temperament as it relates to body, not body image, but sort of body awareness, the earlier you're aware of your kid's temperament traits, the more focused everyone can be on prevention. So so I want you to think about your kid. If you have a kid in mind or 2 kids in mind when you're thinking about this workshop, and I can explain what some of these things mean. So I'd like you to think about your child's temperament traits or inborn personality traits that you've noticed from when they were little. Are they naturally deeper internalizers? So when something happens, like they have a disappointment, not just failure, but when they get rejected or have a disappointment, or in another way to say, like they get dysregulated, does it affect them deeply, and does it take a while for them to settle? You can just write that down on a piece of paper. Another question is for about your kid. Do they process feelings out loud? Do they think out loud about their worlds? Or do they mostly keep to themselves? None of these are bad, by the way. None of these are moral or negative traits. For me, they're like, it's data and functional. These are like my tools to help me understand how to help a kid. Are they more naturally self-critical or more go with the flow? And self-critical, in lots of kids that can be motivating too. So I don't mean that's always bad as well. It can mean, but do they say like, oh, I shouldn't have done that. I was so sloppy. How often are they saying the word should? I should have done better. I should have been nicer. Any shoulds, not just about body stuff. Are they more anxious and sensitive? Are they worried about what people think about them, even at a young age? And that's not just about shyness or like introversion versus extroversion. Meaning like they sort of think about like people are watching them, and I mean like in a normal, observing way. Do you hear your kid talk about, I don't want to go out looking like this, how people will think of me? For older kids, another part of their temperament, and this is even from younger age like preschool, what parts of peer relationships have always come naturally to them, and what's harder for them? Is it sharing? Is it were they always sort of cautious in the beginning and then would always jump into the mix? So it's thinking about that kind of temperament traits of your kids. And so the internally focused or externally focused means intrinsically motivated, extrinsically motivated. So intrinsically motivated means they want to succeed at something for themselves. Extrinsically means for an outside force. So in the eating disorder world, that really translates into intrinsically more means like, I don't like how I look. I think I'm not good enough for A, B, and C. I'm going to change. Extrinsically motivated means like, I've seen this thing on social media, or I've seen my friends losing weight and I'm going to be more like them. Or in order to impress somebody, I need to do A, B, and C. And kids tend to be a little bit more driven by self or, relation to others from a young age. And all that's fine. It's useful information for me as an assessment and also for treatment.
Veronica, there was just a comment in the chat. Someone said my sister, who's 55 now, says when she was weighed in junior high in gym class is when she remembers her eating disorder started.
Yep.
And she doesn't think you're yelling.
Sorry. I'm so eating disorder, there's a long separate discussion, another whole workshop on public schools and BMI and all those conversations and sort of what counts as science and public health in this country. Yes, I'm working on trying to change school weigh-ins, and you're allowed to opt your children out, by the way. I opted my daughter out. You are absolutely allowed to opt your kid out of school weigh-ins. That's my rebellious clinical suggestion. Okay, let me. Yeah, Taryn, I'm sorry about that. It's so common. I mean, and it doesn't happen to every kid. It's I don't know what your sister's like, Taryn, but I don't want to make it seem to all of you that it's a landmine constantly. It's not that every kid is going to get an eating disorder because they were weight at school, but there's just the question I have for public schools is why set kids up for possible failure in that way?
I totally agree. And, to be fair, I was 1 year ahead of her and I don't even remember being weighed. But like you said, since it could potentially be a problem, and why do they need to know?
They don't. I mean, it's a public health thing.
Yeah.
It's a public health
Yeah.
thing from the 90s, because when higher weight bodies started to increase and the obesity discussion became a big thing with kids, there's a whole sociological piece to this. There's some science to it as well, but there's sociological. And the reality is a lot of public schools in Massachusetts haven't updated their curriculum, their public health measures since the 90s. So I'm working with one of the nurses at one of the schools to try to change that. Okay, so let me get to. Did anybody question about social media? I do want to. I'm going to skip to that slide for a minute. I'm going to go back to prevention in a minute, but I want to do social media first, because this is another thing that you guys know. Oh, geez, I'm bad at this. Well, when I said 8, what age do you think? I kind of meant that about the 8-year-old thing, but the reality is the younger you give your kids social media, the more risk it is. That's just the reality. That's the science. The social science is coming out more and more about social media and risk factor for body image disturbance and eating disorders. From my population, the past 10 years, the highest, most difficult app is Instagram. Second is TikTok. But there's also a difference between, this is the nuance of social media. We're not going to get rid of social media. Not all social media is bad. It's a way for kids to communicate. Now that I've put that disclaimer in the conversation, because I definitely have parents in my sort of peer world who ask me a lot about this, because our kids are now teenagers and they ask me about this a lot. And a lot of parents don't like my answer. I say, put off social media as long as you can. That's different about the phones. Put off social media as long as you can, especially content creation on their end. So I do feel like there's a difference between kids who scroll sometimes too much, and kids who find, body image or sometimes pro-anorexia websites. We'll get to that in a minute. I think there's a slight difference between observing social media, which could be equated to watching TV, and kids who actively post content, pictures, videos, and then get feedback. So get likes, dislikes, bullying, all that stuff. When kids social media content create at younger ages, the risks are much higher. If you have a kid temperament wise who never gets bothered by negative comments in their personal life, they might be the unicorn who can deal with all social media at young ages. And not all kids react the same way. That's why I asked you the temperament question, because temperaments are different. And some kids really love social media and they want to scroll, and some kids are like, oh, cool, Snapchat, whatever. The answer really is know your kid in terms of prevention, when they should get it. Know your kid first. If your kid really has FOMO, fear of missing out, if your kid really, cares what people think of them, cares what their outfits are, cares whether or not they're doing the wrong thing. If your kid uses the word should a lot, I should do A, B, and C, then social media is probably not a great part of their lives. And like I said, it doesn't always cause eating disorders, but it's riskier. I sort of say, if you want like an age for anorexia for social media, I'm like 16 maybe, more like 30. No, I'm just kidding. But there's just too much, I have too much data on all this. Okay, we have about 15 minutes before I'm going to answer questions at starting around 5, I think. Is that true, Anjali?
Yes.
Okay, so let me see what slides I have left. I've gone a little bit off not script, but off order of my slides, but okay, the 4 last slides I want to go over is the doctor's office. So talking about the doctor's office, talking about looking at prevention identification, the dual efforts on those. Let me just put this up. Okay. As I said a couple of minutes ago, it's never too early to prevent future eating disorders, negative relationships with food or body image struggles. It's never too early to what I call protect their body image, or protect the integrity of their body image, sort of protect their body trust early on. So in the doctor's office, to me, that can mean a couple of things. How to talk to the doctor, how to talk about bodies, your kid's body at the doctor's office. For younger kids, even under age 8, for me, this is just my personal, professional and personal opinion, is that for younger kids, I would often encourage any discussions about weight or body size or any of that outside of earshot of your kid. Weight and body shape talk should be at a minimum during early years of child's development. I actually, for me, I didn't let NAP doctors talk about my kid's weight in front of her at all, still. She's 13 now. And I think they're like, you're crazy. And I'm like, no, I'm not. But that's personal. But professionally speaking, I know that when kids come to the doctor's office and they hear parents talking about them to the doctors, not about ear infections, not about their lungs, but about body, kids, they don't really necessarily clue into that till age 8, 9, or 10, but practicing from an early age that it's not something that the families are kind of focused on, even earlier ages, I think is setting up for prevention in that way. And so the idea is for body trust. How do we preserve your child's sense of body autonomy, integrity? And I don't mean like integrity, like a good body. I mean like picture a body image shape, and integrity means like a solid line, that it's not porous, that it's not being that's not being picked at by negative influences, like, not just social media, but like negative talk about their bodies. Like how would we as parents and providers preserve the solid line around their body image so it was more impermeable? Because that's what I was thinking about. My example for this is how we talk a lot about these days, especially, we talk a lot about sexual assault, we talk a lot about consent, and we talk about saying no, and we're trying to teach that at even younger ages, which is fantastic. However, part of that is knowing, we are allowed to have boundaries. We talk a lot about boundaries and personal space, and kids can't, push each other in elementary school, or they can't, boys aren't flirting with the girls anymore, sorry. And that doesn't mean that they like if a boy's being mean to you, it doesn't mean that they like you, or those kind of things that are very old tropes. That's all great about sexual space and consent and boundaries, but I would love to fold in body neutrality and body autonomy and integrity into that lesson. That was my next goal with elementary schools, because the idea is, it's great we can say no to someone touching us, but I would also love for kids to say no to negative body talk about them. Or another example for that is, like, we're teaching a lot of kids these days that they can decide whether or not they hug a grandparent or an uncle or an aunt. And that's, I think, really important, because when you give a kid permission to hug another person or to be hugged, you're giving them body intuition about whether or not they want to be, you're giving them body choice at an early age about hugging. And that's not just about space, that's also about them, you're preserving their body intuition, if that makes sense. So so it's not just about, like I said, personal space in that way. The more that you protect their intuition around body space and body usage, even like sleep, right? Like body regulation around sleep. Do they know when they're tired? Do they know when they are cold? Like those are simple things, but part of prevention is keeping body intuition intact. And that's why body neutrality to me is more powerful than body positivity, because body positivity, especially in our cultural moment, says love your body. You have to love it all the time, and you have to speak positively about it. But part of that's an attitude. And the reality is we're not happy all the time, and we don't have a positive attitude all the time, and not about anything. Body neutrality is more, and to me, is more of a concrete science sort of body systems approach. It's more like my body is functioning today. Did I go to sleep? Did I drink water? Did I fuel it with energy, like food energy? And I think body neutrality is a little bit more, what's the word? I think it resonates, or it resonates more with the concept of that we're always sort of, flexible in our moods and our body states each day, and we're not just always body positive, or we're not just always in a positive mood. So my goal with prevention is looking at body trust, integrity, intuition, body neutrality, and that's going to intuitive eating. This slide is much longer, and I had to cut it down. I have a link to it in the end, the last slide. Intuitive eating is not just our treatment, one of our treatment interventions that any of you have ever met with a Health at Every Size nutritionist or ever heard of that. We work with the concept of intuitive eating as prevention and treatment. So some of this sounds sociological, reject the diet mentality. That's kind of like when you're more aware of diet culture at ages, say 10 and older, or for a parent to reject it. But honor your hunger is a lifelong thing. For kids to say, I'm hungry, my intuition is telling me I'm hungry and I'm going to eat. A plus B equals C. Part of intuitive eating, part of trusting your body, part of preserving body integrity is keeping relationship to food math a little bit more simple, right? The more, I tell it to kids all the time, I equate it to math. The more variables or numbers that kids have in their equations for food and body, the more confused and overwhelmed they get. So, and this is, in an ideal world with all factors controlled, but the ideal for food, intuitive eating, and body trust is that they have a cue, they meet the cue's needs, and then they move on with their lives, and they're not still thinking about it. Satisfaction factor, feel your fullness, cope with emotions with kindness, respect your body, movement, feel the difference, which is different than exercise, honor your health, gentle nutrition. Like I said, there's a link at the end of this slideshow for to get the bigger descriptions of all these. And this is a concept, intuitive eating, that's making the rounds in pop culture. And it takes a little bit of I'll say this also requires a level of, privilege, meaning, and I don't just mean lack of food scarcity, but I also mean that there's, that you have time and energy in your life as a patient, a kid, or parent to work on the intuitive eating, because it takes time and requires, households aren't, if there's a comorbid or accompanying issue of trauma with a kid who has a lot of trauma or a parent who has trauma, it can be hard to, this is like a end goal that's, there's a lot of things that can be in the way first. So I just want to recognize that it's not, it sounds easy. Hey, you're hungry, eat. But I know it's not actually that easy.
Veronica, there is a question. Do you want to answer it now?
Sure.
Related to intuitive eating, what about a teen who says they are full after very small portions and is very thin?
I mean, there's a lot of questions of that, like what I would want to know if their food had changed recently, or if they always just knew they were full at an early age when they just ate small amounts. Like the questions aren't necessarily, are they the math of like eat then full? The question is what sort of around that statement. I'm not hungry and I'm full don't have to be disordered. But I think it depends on is like I'm full. So the thinness itself and eating small amounts does not worry me. It's how recent saying I'm full and how old that kid is. So that's a. So this is a bigger discussion as well as parent role modeling. This is also back into the prevention model of having kids and then wanting them to be body neutral or at least not body critical. And I know a lot of I've met so many parents at this point who want to understand whether or not some of their own body stuff and is contributing. And the simplest ways is the two simplest things I've ever kind of suggested to parents is you don't have to constantly say around your kid, I love my body, I love my body, I love my body. It's more not making bodies the focus of observation so much. So, ideally not criticizing your body at all or others, but like sometimes I even notice I've become in this field, I've been so hyper aware. I was sitting on a couch one time with some people and we were watching something and I heard the person pick apart somebody on the TV. And I remember thinking like, it's so natural to do that. And so once I had a kid, I constantly started interrupting that at an early age for my kid. So that's the second part, interrupting negative body talk. This is sort of like the social justice-y piece of my work, thinking about disrupting. How do we become disruptors of body image issues and in diet culture? It's not just by saying to the kids, diets are bad. It's actually so your kids can see you interrupting negative body talk around you. If you have an aunt or an uncle who constantly talks about their body in front of your kid, it takes a little courage, but saying like, we're just not doing that. We're really not doing that in front of my kid. So even if the kid still heard the uncle or the aunt, the fact that you as the parent is role modeling, interrupting and like having the courage to sort of interrupt in a situation. I mean, even in a social situation, at a party or something, or on a vacation, or the worst is before Thanksgiving when someone's like, I'm not going to eat all day so I can have Thanksgiving dinner. Just if you're feeling courageous, one of the ways you can help role model your kids is having them see you interrupt that. Or like, don't say like after you eat, I'm going to unloosen my belt. I'm going to unbutton my pants. Like some of these things, I don't want you to think are so hard. They're small baby steps that actually start building. They create the building blocks for your kids not to be so hyper aware of their own bodies and whether or not something is wrong with them. The last, do you think you can put these in this? Oh, I can do that. Oops. I'll put these in the chat in a second. Oops. This poet, Nikita Gill, is one of my favorites. And I added sons because I realize this is just about daughters, but I'll let you read that for a second. I'm just going to grab some water while you read that for a second. This is one of my favorite poems about the biopsychosocial model of bodies. I know this sounds a little body positive too, but I just love how it talks about the nature piece of it too, and our ancestors. And Okay, so I'm done. Shockingly, I did it exactly in the right amount of time. And I'm going to put that information, the links on this chat. And then if anyone has more questions, like I said, I can't give you specific things about your kid right now, because not just because it's like HIPAA, but because it's complicated. But you're welcome to do a parent. If you don't want to bring your kid in, I love doing consults at NAP. Oh, that's a messy slide. Okay. So I'm happy to do parent consults even via Zoom. I don't like doing kid assessments on Zoom for the first time, but I'm happy to do a parent consult on Zoom. Okay.
Veronica, related to the last slide, you were talking about like interrupting that conversation when people are maybe dissecting other people's bodies in front of kids. What if, like, how would you respond to your own child if they're critiquing? Because obviously as parents, when we say like, oh no, you're not fat, you're not this, it's complete rejection, right? So how else would you like phrase that, like for a parent to say, or would you be more like curious, like, why do you feel that way? Or
Yeah, I would
etc.
never say don't. First of all, if we say you're not fat, that's, to be very, radical fat activist here. That's fat phobic to say you're not fat. Because reality is maybe they are. Like, let's go back to our, like, if I'm doing my base, I know that fat is not good in this culture, but like, if I'm going to be true to my like social justice roots, we have to like try to at least normalize the concept that fat is not inherently bad. But the question, the point I think is more important is what do we say to our kids in general when they're sort of saying things? It's like, you're right. It's Anjali, it's more about being very curious, and then I usually tend to ask questions like, what are you really afraid of? Like, I just go a step deeper. I mean, and I do this with my own kids, but although that's luckily hasn't been, well, knock on wood, but like I'll ask kids, like, I'm so afraid of getting fat. I'm like, okay, and what's the step after that? And for kids, it's usually, well, then I won't, be happy, or I'll get rejected or something. So then I start working with the deeper fears. So for your own kid, I think it's, not just why do you say that, but, oh, I hear some fear. Like, you go to the emotion part, like the emotion you hear in a way. Any other questions? Was there a question?
This comment is more feedback. This has been so helpful. I love your message and your social justice approach to this issue for our whole society.
Oh, thanks, Taryn. Yeah, I mean, I treat plenty of boys too, but the reality is for every one boy I treat, there's 10 girls. And so the science is still not in girls. I should say the data is still not in girls' favor.
Can I ask about how we would arrange to have a parent consult with you?
How does it again, Anjali?
Do we just call NAP to arrange a consult, or do we reach you directly?
Yeah, it's through NAP. Yep, like through
Okay.
the rest of IBH, behavioral
Okay.
health. Yep.
Can I ask a question,
Thanks.
Veronica?
Yeah.
Yep.
I'm just curious a little bit more about I forget what it was called. It was like
Orthorexia.
Yeah, and just like when, I know you said don't bring in our individual kid situations, but I'm just curious about like when just what could be just a true interest in like being healthy and eating well and exercising is like tipping more over in that realm.
Yeah.
I feel like my daughter is a serious orange flag, but not a red flag.
Yeah.
And we've been so confused about like, are we worrying too much, or I don't know. It feels like there's a lot of orange flags, but not a clear red flag.
Yeah. Well, just tell me, I'm not going to do a whole assessment, obviously, but what age is that kid?
2 weeks away from turning 13.
Yeah. Well, the reality. So this is why orthorexia is complicated, and I can encourage you to, you can play Google Doctor a little bit after this, and there's some good videos on YouTube about orthorexia and why it's like, do you know what cognitive dissonance is? Have you heard that phrase? And like it creates that the dissonance because you're thinking two things are true at once. And
Right.
orthorexia is one of those that creates so much cognitive dissonance because, like I said earlier, we're trying to, the idea is, well, I'm trying to do something healthy. And so when does it tip over? But the problem I see with kids is that I'm not quite sure why 12-year-olds all of a sudden want to eat. I mean, I still need to assess your kid, but I'm not quite sure what it is about 10 to 13-year-olds who are also like, I want to be healthier. I'm like, what is it about a 10 to 13-year-old that it's not healthy?
Right. Right. And
You know what I mean?
when my daughter was 11, it was like very suddenly she turned vegetarian and like
Oh, yeah.
kind of the healthy kick started and like major weight dip, etc.
Yeah, you should come see me.
Yeah.
I mean,
Okay.
even just you, like, I don't want to pathologize kids overly right away, but
Yeah.
that's like sort of, and that can be just orange flags. You're right. And it might not, and she might outgrow some of that, but that's the thing. That's what worries me about this age. So
Right.
kids were like, oh, that's what I'm saying. Like, all of a sudden they become very aware of like self and others. And they're like, well, I'm going to do all these healthy things. I was like, I don't know about Gen Xers here, but none of us were doing that at 10, 11, 12. Eating disorders have always existed. But some of this like wellness, health, exercise piece of it feels a little bit younger to me. You know, and back in the college days, I felt like anorexia or some bulimia was a little bit older. And I am seeing more middle schoolers with sort of early restrictive habits, or orthorexia, like healthy, like even paired with like, you know, they might be eating enough amounts, but they are more doing more exercise, and they start getting a little bit anxious about missing an exercise day, or they start planning their life around exercising at like age 12 or 13, 14. I'm like, ooh. And they start becoming scared of food. I mean, I don't know about your daughter, but like 11 to 12, 13-year-olds, you know, guys, they don't have executive functioning frontal cortex yet as well, prefrontal cortex as well as they should have. And so some of it's like you're putting like a, you know, like a pinball in their brains, an idea like a healthy eating, and then it's just like bouncing all over the place and lighting up different parts of their brain and saying, well, that looks good, that sounds good, maybe I should avoid that, maybe I should do that. And we could talk it through. I can get more about your kid, but yeah, orthorexia is just a little tricky, but look up, there's a couple of explainers on YouTube that even like nutritionists have gotten it before, because they're pretty focused on like healthy eating and like nutrition eating. And I'm like, oh my gosh. Anybody else?
I'm wondering, on a parent consultation with you, I guess let me give you a little bit of background. So I have a nine-year-old girl, who's a pretty, she's having some challenges around her eating, a number of things, food allergies, sensorial stuff. She also has quite the sweet tooth. And so I probably have an undiagnosed eating disorder myself. So I'm kind of coming at it from that perspective, as in I don't want to talk about, you know, limiting this or that or the other thing. And then her dad worries about, well, she's eating too much sugar. And so, you know, like, we're having the conversations about, you know, if you're quote unquote going on a diet, that's your business, but let's not talk to the girls about it. But so I guess my question is, would part of our consultation with you be a little bit of education for us parents? Okay, cool.
Yeah.
Because I'm trying to find balance.
Yeah.
Like, what's the best way to talk about, especially about sugar, to her? Because I don't want to demonize food. I don't want to do to her what people did to me when I was a young kid. And
oh, I love that.
You know.
I love that. Yeah. And that's what I love about working at NAP, is that I get to work with the parents in that exact role. Like, we don't have to have, you said your daughter's 9?
She's 9. I also have a 15-year-old, both girls.
I don't want to bring a 9-year-old and be like, I mean, the 9-year-old could come in, but I love the idea of talking to parents and empowering you all to think about how you're not as scared of these topics, or how to normalize your own eating, or to avoid some of the traps that you were in when you were younger. Because
Mhm.
if you're a little bit more confident at home, even just a little bit, that does trickle down to your children. So I'd love to meet you in the office. Yeah. So
Awesome. Thank
yeah,
you.
or just like we can Zoom on totally, even a
Mhm.
one-time thing. Sometimes I love doing one-time things. That's great.
Thank you.
Yeah. I'll look at my sheets here. Yeah, I do think I've been at NAP for a year, and I feel like I love NAP, and I think all of them are trying to, they really are motivated to fully understand. These disorders are complicated, and they're very motivated to understand the complexities of them. But I really have enjoyed being at the medical home versus I used to be in private practice and kind of see kids when they were a little bit more in the depth of the disorders. And now I'm in at NAP, and I think that role lends itself to more education, parent work, and prevention and early identification, because that's really like, yeah, thank Karen. That's just sort of the ideal is because these, if I'm going to get to the dark side for a second, because you're adults and you can probably hear the dark side. If a kid develops a full-blown one, it can take anywhere from a year to 6-7 years to recover from it. Depending on their protective factors, depending on their risk factors, which we didn't really talk about, whether or not they have a lot of confounding variables. Kids who come with sort of like a genetic, they win the lottery genetically, meaning like there's a lot of anxiety in the family, a lot of depression, some OCD, there's some mood issues. And maybe they have some trauma in their background, and then if they get to 13, and then they also, feel very out of control and start using food in relationship to food to deal with their bodies. That can be harder to sort of unravel and recover from, but there's just a spectrum of how intensely people deal with this issue. And it does become like a family issue, kind of like drugs and alcohol. It does become a family issue in that way. And family-based approach, when I wrote that, when that's part of the blurb, is that it's not so much that you guys have to fix every part of their food and relationship to body, but that it does these issues do affect families at a pretty deep level. So. Nothing else. Oh, I actually was going to put one more thing in the chat. Happy Valley Nutrition. I just put the name. Anjali, can you find the phone number?
Yes, I'll post it.
Yeah, Happy Valley Nutrition, I think, is in Amherst. Amanda Mittman is the head person. I work closely with her. What I like about Happy Valley Nutrition is they have a couple of providers. One's named Morgan and one's named Dominique. And they are both adolescent specialists with a background in eating disorders. So they're not necessarily treating your kid at Happy Valley as though they have an eating issue, but they're very good at health at every size, intuitive eating. They're good at parent coaching. And their practice has been built up in the past couple of years to a bigger health at every size approach, which you can look that I have a link on the chat about health at every size. Anyway, so Happy Valley is the other resource I was going to say. In the Valley, eating disorder providers, we're far and few between due to COVID. The wait lists are not as bad as they used to be, but they're not great. I mean, they're still longer than I would want them to be. So Happy Valley Nutrition has been a useful supplement to anything I'm doing. And they just get it. They just understand how complicated this can be for younger bodies and for families. And they work with boys, girls, non-binary, anything, kind of like we do at NAP. So we do the spectrum of identities and people, and it affects everybody. It certainly affects trans, non-binary, like I said, affects boys, affects LGBTQ. It just affects everybody. Another time we'll do an academic study dissection of all the actual eating disorders for anyone who wants to be nerdy about it. But if you love kids like I do, there's a reason why we want to, you know, not just prevent, you know, bullying in schools. We want to have them have body trust more than anything else. That's my motto, body trust for all of us. For everyone. And name all my future lectures that way. Body trust for everyone. Okay, we all set? I mean, we have time, but if everyone's done. My Declaration of Independence.
Yeah, if anyone is interested in a consult, the best way is to just call NAP to set that up.
Yeah, I was supposed to say that speaking of this is like, I could go on and on, I can riff about this all day, but like body liberation movement sometimes feels like sexuality and, you know, body identity, but it's like, and it's not just, and to me, it's not just fat activism as well. It's also about body trust. Body liberation is that you have body integrity, and the line around your body image is intact. That's what body liberation means to me. It's not just a nude beach. I'm sorry. Okay, sorry.
Just say before we end, the next education series is May 21st. And funny enough, it's also about health and eating. It's by Dr. DeJane and Michelle LaRock, who's a registered dietitian. It's about raising happy eaters, how to help your child learn to love healthy food.
Oh,
So it's funny, they're kind of back.
yeah. Can we stay
Back to
online
back,
after
so.
we talk after everyone leaves for like?
Sure.
Okay.
Yeah. Anyone else have last minute questions, comments?
Adios.
Well, have a good night, everyone. Thank you for joining us.